effectiveness of novel treatment therapies that are entering into the treatment landscape, particularly in that relapse refractory large cell lymphoma space. I'll walk you through those abstracts. We also saw updates on the bispecifics, both in terms of updates to the pivotal single arm studies, but also some of the early results from combination strategies and how that might potentially impact the treatment landscape looking forward. We saw updates to liso-cel in follicular lymphoma, particularly in that second line high risk population. And then I'll end with an interesting approach to low dose radiation for gray in gastric malt lymphoma. Kicking off, we saw real world evidence of liso-cel from the CIBMTR cohort of patients with over 600 patients that were planned for commercial product. One important limitation of this analysis is that they excluded those patients who did not receive a commercial product. And those of us who treat these patients recognize that there's not an insignificant number who have an out-of-spec product that then receive treatment on an expanded access protocol. Nonetheless, we see, again, a healthy population of patients that received a commercial product, and that way we can explore some of the practice patterns in terms of what are the patient characteristics and disease characteristics that comprise this cohort of patients with nearly 400 reported on. You can see there's a small portion of patients that had high-grade B-cell lymphoma, a small portion with active CNS involvement. These patients were pretty heavily pre-treated with almost a quarter having had at least 4 or more prior lines of therapy. And over a third received bridging therapy. It's also important to recognize some of the perceptions regarding the toxicity associated with liso-cel, and that a good portion were actually over the age of 65. As a result of those older patients, they tended to also have more comorbid conditions than what we saw in the prospective single-arm studies. Nonetheless, we see very impressive objective response rates and even complete response rates in this portion of patients, that many of which would not have met the eligibility criteria for the Transcend study. And though limited by relatively short follow-up, the median duration of response had not been reached, and over 60% of patients at a year were still maintaining their response. Similarly, we saw favorable outcomes in terms of 6-month and 12 months progression-free survival estimates, as well as overall survival estimates, again in an older patient population with multiple comorbidities that were heavily pretreated, reinforcing that liso-cel should be considered for patients as part of standard of care practice. And intriguing, we saw reports of CRS and ICANS that were quite manageable, many of which were grade 1 or 2, very low rates of grade 3 or higher CRS or neurologic toxicity. And that translates into relatively low rates of corticosteroids or tocilizumab or the combination to manage these toxicities. So in summary, in this cohort of patients who received standard of care liso-cel across the United States, a much larger sample size than what was reported in the pivotal single-arm phase 2 trial. Not surprisingly, we see patients that would have not met the strict eligibility criteria of a prospective study. Nonetheless, we see comparable outcomes in terms of response rates, durability of response, progression-free survival, and overall survival, including in a population that was enriched for high-risk features, including CNS involvement. Toxicity was quite manageable, and so I do think that this should be considered for patients that even maybe providers have concerns about tolerability of CAR, given this is one that demonstrated. Second cohort, this is a smaller subset, but a little bit more in-depth look at some of the baseline characteristics. I participated in this cohort. It's 8 U.S. academic centers with a lot of experience utilizing all the FDA-approved CD19-directed auto CARs for lymphoma. And again, we see generally patients that receive liso-cel as opposed to the other options available tended to be older, with over a third of the population being 75 years of age or older, again, enriched with comorbidities with a Carlson comorbidity index of 3 or higher in 2/3 of the population, and about a third that would not have met eligibility criteria for the prospective pivotal phase 2. And again, we see about 11% of the population having active CNS disease. We also had the opportunity to look more closely at bridging strategies utilized, with 2/3 of the population nearly receiving bridging. And we're seeing more polatuzumab-based bridging utilized. Complete response rates were approximately 20% to that bridging strategy. And not surprising, those patients who have a good response to bridging generally do more favorably with cellular therapy, suggesting that disease reduction or tumor volume reduction can be an effective strategy to try and improve outcomes. And again, a small subset of patients with CNS disease, but it is encouraging to see some durable CRs in this very high-risk patient population that's otherwise facing dismal outcomes. So to summarize, this cohort of patients who received commercial liso-cel, again, tends to be older, potentially frailer patients, but quite comparable efficacy and safety in this cohort of patients receiving standard of care liso-cel. Another analysis looking at CIBMTR data was the exploration of bridging therapy prior to standard of care axi-cel. So if you recall, the prospective studies only allowed for corticosteroids as a bridging strategy among patients receiving axi-cel on prospective studies. But we know in the real world that the majority of patients may actually be considered for bridging in an attempt to control disease while patients undergo leukapheresis and manufacturing. And as I just showed, having less disease going into CAR may actually improve both efficacy and toxicity. So this is a large cohort of nearly 1,500 patients looking at the type of bridging utilized. So CD20 antibodies in combination with chemotherapy is one of the most common strategies employed in the US, and then the breakdown of those systemic therapies. Our GEMOX at the time of this report tended to be one of the more frequent chemotherapy regimen backbones, though in my practice, and I think in others, we're seeing more utilization of polatuzumab-based approaches. When we look at the effectiveness of those that were bridged versus those that were not bridged, I think a major limitation of these types of retrospective studies is there are clearly going to be differences in the baseline characteristics, i.e. those patients that were considered for bridging likely had higher risk features such as more advanced disease, higher tumor volume, elevated LDH, etc. And so when we look at the outcomes, particularly in terms of PFS and overall survival, those who don't require bridging therapy have more favorable outcomes, not surprising. That being said, the safety looks like it could potentially be mitigated by reducing the amount of disease burden with strategies that are effective, such as bridging, but that's going to be at a cost, particularly prolonged cytopenias and the potential for infections. So in summary, despite bridging not incorporated into the prospective studies exploring axi-cel, in the real world, a large portion of patients do undergo bridging, and that is aimed at trying to mitigate some of the poor risk features that we know are associated with less favorable outcomes with a resource-intense approach such as axi-cel. And so I do think there is a role for bridging therapy and that we don't see far less favorable outcomes. You do have to be mindful of the potential for prolonged cytopenias. Now, we also looked at outcomes with other novel therapies, not just CAR T, given the number of treatment options that have emerged in the last few years for the management of relapsed refractory large cell lymphoma. So this was a large academic center derived cohort of patients in that second line or later space, looking at these novel therapies. Practice patterns delineated when are these therapies entering into the treatment landscape and what are their outcomes. So not surprising when we look at this, age is a factor. Generally, chemotherapy is utilized in younger patients, whereas therapies such as tafasitamab are used in patients that are much older. Similarly, more favorable ECOG performance status used when choosing among chemotherapy versus targeted options. IPI was more higher risk among those patients receiving targeted therapy, particularly tafasitamab or loncastuximab, and patients receiving chemoimmunotherapy are much less heavily pretreated. And those who have had prior CAR T-cell therapy are generally considered more frequently for targeted therapy, including other CD19 targeted approaches such as tafasitamab or loncastuximab. Here we report the physician-determined objective response rate across these various treatment approaches. And you can see that the overall response rate, and again, reported according to those who'd had prior CAR T-cell therapy or not, in general was quite modest, a little bit more favorable among those, particularly with chemotherapy-based approaches that had not had prior CAR T-cell therapy, maybe a little bit more favorable among those receiving loncastuximab. In general, the progression-free survival was quite poor, ranging from 1.9 months among those receiving chemoimmunotherapy to 3 months among those receiving loncastuximab. And overall survival was also surprisingly poor in this cohort, ranging from 4.7 months to 9 months. And you can't compare across the treatment groups given the dramatic differences in the baseline characteristics, including the fact that those patients receiving Lonca were very heavily pre-treated, enriched for high-risk features, including having had prior CAR T-cell therapy. But our summary was that despite a number of novel targeted agents entering into the treatment landscape, the outcomes for patients with refractory large cell lymphoma continue to be poor, and we see enrichment or overrepresentation of those with primary refractory disease being referred to tertiary academic centers. So this may not be reflective of community practice at large. This also doesn't include patients who've received standard of care bispecific antibodies, which are the most recent treatment to enter into the treatment landscape. But there are two important things to consider. We definitely need more clinical trials done in this space, and we shouldn't restrict it to those or restrict patients who've had prior CAR T from participating, given some of their outcomes were also quite poor. Speaking to the bispecific antibodies, we did see an update to glofitamab, which is a CD20, CD3 bispecifics. We now have extended follow-up reported with this single agent in that third line or later large cell lymphoma space. And for those patients who achieve a complete response, whether they've had prior CAR or not, they generally do much more favorably than those who fail to achieve a complete response in terms of overall response and duration of complete response. Are there clues as to who might be more likely to achieve a complete response? Well, total metabolic tumor volume, if it was lower than the median, had much more favorable outcomes than those who had higher total metabolic tumor volume, suggesting, again, similar story as what we've seen with CAR T, going into a therapy where you're utilizing T cells to eradicate tumor cells, the lower tumor burden, patients are going to generally have more favorable efficacy. And we also saw actually lower rates of grade 2 or higher CRS, again, for those patients in the lower quartiles in terms of metabolic tumor volume. So not only does it potentially predict for enhanced efficacy, but also better tolerability. The challenge, though, is for those patients with poor risk findings, it's still one of the most effective strategies we have. So I wouldn't restrict this treatment to those that are just good candidates, but be mindful that those with higher tumor volume are going to have less favorable outcomes and potentially more toxicity. The other question is, should we build on these therapies? So we saw reports of mosunetuzumab in combination with polatuzumab. So mosun is a CD3, CD20 bispecific approved in follicular, not large cell lymphoma. And it was combined with polatuzumab, an antibody drug conjugate targeting CD79B. You can see the schema here. Both were started essentially on day one, so you don't have as slow of a ramp up to get to that sort of target therapeutic dose. And we saw quite impressive efficacy, both in terms of objective response rate and complete response rate. It's a single arm phase 2. There's no head-to-head comparisons. But if you think about the historical outcomes with mosunetuzumab alone, particularly in large cell lymphoma, it was not nearly as favorable. And these PFS and OS estimates at 2 years actually look quite comparable if you think about what we've seen with CAR T-cell therapy outcomes, albeit probably in a different patient population. But again, favorable PFS of 11.4 months, favorable median overall survival of 23 months. And it's at potentially even better toxicity than what we've seen with the single agent outcomes with bispecific antibodies. Again, you can see here that there are neutropenia that is observed, fatigue is observed, but when we look at rates, particularly of CRS, they're quite low, quite manageable, confined to cycle 1, mostly grade 1 or 2, and again, quite low in terms of overall incidence and 100% fully resolved. So the summary of mosunetuzumab in combination with polatuzumab is that the efficacy looks quite intriguing, particularly in that relapse refractory large B-cell space, including those that had had prior CAR T-cell therapy, and it could easily be given in an outpatient setting given the low rates of CRS, and particularly the fact most were grade 1 or 2. There is a randomized study underway looking at mosun plus pola versus standard care to know if this is really better than the other available options to these patients, so stay tuned. We saw updates to mosunetuzumab monotherapy in relapse refractory follicular lymphoma. We saw the 3-year update. Again, this is a single-arm phase 2 that led to approval of mosunetuzumab in that third line or later space. You can see here the duration of response, again, looks to be identical to what we saw reported almost a year ago now. And as we've seen with glofin and large cell lymphoma, the duration of CR is much better than the duration of partial responses, suggesting that for patients who have a CR, they are likely going to experience quite impressive durability with a fixed duration of treatment. The patients who achieved a CR in the study stopped after 8 cycles, suggesting also that we probably can't overcome the fact of those patients who only achieve a partial response have a quite short duration of that response. So then the question is, what should we combine mosunetuzumab with? And lenalidomide is an obvious choice because it's an oral cell mod that's going to enhance NK and T cell activity. And so this is a study in frontline follicular lymphoma looking at mosunetuzumab in combination with lenalidomide, because we have seen safety data in the relapse setting that looks promising. So this is now moving up into frontline, and you can see the study schema here. Len has continued for 11 cycles, mosun continued for 12 cycles. In regards to adverse events, this is subcutaneous mosunetuzumab, so not surprising. Cutaneous reactions, particularly in the form of rash, was observed and in higher instances than we've seen with mosun IV monotherapy. Fortunately, most were grade 1, 2. We do see some injection site reaction. Neutropenia and CRS are some of the other common adverse events, but again, were manageable, and there were no grade 5 adverse events and only 2 AEs that led to treatment discontinuation. Cytokine release syndrome was also quite favorable, again, mostly grade 1. We do see 3 instances of CRS occurring during cycle 2, again, likely speaking to the fact that you have the addition of lenalidomide. 100% of the cases resolved. No corticosteroids was necessary to manage the CRS. 2 patients had tocilizumab, and again, no CRS that led to discontinuation of mosun was observed. Response rates are quite favorable, nearly 92% objective response rate, 89% complete response rate, short follow-up, so that's a major limitation of this study, only 5 months of follow-up, and it is a relatively small sample size. That being said, you can see here the swimmer plot looking at where these patients are in terms of response and duration of response, and so it is encouraging what we're seeing in terms of efficacy and safety of mosunetuzumab subcutaneous in combination with lenalidomide in frontline follicular lymphoma. And as a result, a phase 3 study is planned looking at mosun plus lenalidomide versus our chemotherapy in frontline follicular lymphoma. As I alluded to, we did see updates to the Transcend study, which is a single-arm phase 2 of lisocabtagene maraleucel in relapsed refractory follicular lymphoma. Several different cohorts. This summer, we saw the reports of the 3rd line or later cohort. At ASH this year, we saw the 2nd line cohort. So to qualify for this in 2nd line, patients had to have POD24 status, meaning progressing within 24 months of chemoimmunotherapy, or have had prior chemoimmunotherapy, are relapsing, and meet modified Gelf criteria. So this cohort's a relatively small cohort of 23 patients versus the 107 that were in that 3rd line or later space. But because of the eligibility criteria, again, we see nearly half were double refractory, nearly 2/3 were POD24 following frontline chemoimmunotherapy, and about 22% received bridging therapy. The objective response rate, which was the primary endpoint of this study, was 96%. Intriguingly, all of these patients had a complete response as their response. And so the primary endpoint of this study was met. Relatively short follow-up, nearly 18 months, but the median PFS has not been reached, and the 12-month estimate is 91%, which is quite favorable. And again, potentially hints here that utilization in earlier lines, as early as second line, may even result in more favorable outcomes. Again, small subset here. Toxicity does not appear to be different in that second line versus third line space. Similarly, CRS and neurologic toxicity was quite manageable. A little over half of patients had CRS, 17% had any grade neurologic event. Most were grade 1, 2, only one grade 3 neurologic event, no grade 4 or 5 events observed. Very low rates, again, of corticosteroid and or tocilizumab used to manage this toxicity, which is also quite encouraging. In terms of other AEs of special interest, the prolonged cytopenias were actually quite infrequent, particularly in those that are less heavily pre-treated, only 13%. There was one grade 5 treatment emergent adverse event of HLH in a patient that was in second line and had a POD24 status. So in summary, liso-cel in second line or later follicular lymphoma resulted in very high response rates, 96% complete response rate, and with about 18 months of median follow-up, we've not reached the medians in terms of duration of response, PFS, or overall survival. And so we're anticipating that this will lead to approval of liso-cel for relapsed follicular lymphoma, and a randomized study is currently underway looking to see if this is better than the other available options. So the last thing I'll leave you with was an interesting study looking at low dose 4 gray radiation for gastric malt as definitive therapy at our single center at MD Anderson. I would think most people will recognize that radiation is still a preferred option for gastric malt, as the majority in the US are actually H. pylori negative. Though there are questions as to what is the preferred dose of radiation, and we all worry about the late toxicity associated with radiation, which usually is associated with the dose and the treatment planning. So there is room for improvement, and we know that malt lymphomas are exquisitely sensitive to radiation. So this is the study design, and that patients were started at 4 gray, so that's 2 fractions, and then they undergo reassessment at 3 months. For patients who are in a complete response, they're just observed. For those who have a partial response or minimal response, they're monitored for an additional 6 to 9 months. For those with stable or progressive disease, then they would then complete 20 additional gray, so a total of 24 gray. Here is the treatment delivery. So again, there is some expertise in this in terms of the treatment field, the equipment utilized. Patients were advised to be NPO for 6 hours, preferably overnight. They were pre-medicated with ondansetron, given the risk for potential nausea induced from treatment. And there was review as part of our standard of practice procedures. Here are the baseline characteristics for these 24 patients. Intriguingly, 2 had prior systemic therapy prior to radiation, and there were 6 patients that received antibiotics, 3 of which had H. pylori positive disease, 3 were negative. And all patients had confirmed disease prior to proceeding with therapy. So among those 24 patients, 20 achieved a complete response with 4 gray only. Among the 4 with residual disease, they went on to receive an additional 20 gray, and all of those patients had a CR with this adapted radiation response. Here is the local disease control, again, if you take all patients, and then the freedom from distance relapse. So very good local and disease control outside of the radiation field. So based off of these results and other encouraging results with low dose radiation, there is a randomized study underway looking at 4 gray versus 24 gray to really know if this is truly better than just 24 gray. But I think it's encouraging nonetheless, and that, again, quite effective strategy that's very well tolerated. So I'll conclude by summarizing that the real-world outcomes in large cell lymphoma continue to look promising, particularly as it pertains to CAR T. However, that is a small subset of patients, and the targeted therapies are commonly utilized in pretty heavily pretreated patients, and those outcomes are less favorable. Bispecifics continue to look promising. The CRs particularly appear to be durable, maybe better efficacy and better tolerability in those with lower tumor burden going into treatment. And the combination strategies, I think, will be a promising next step, given that the tolerability of the bispecifics is quite encouraging. I think we all wonder, is there a role for CAR T in follicular lymphoma? And I do think that particularly with liso-cel, given its improved tolerability, should be considered particularly for those patients that are young with high-risk features. And then how will we choose between the CAR and bispecific antibodies? I think this where the disease-specific characteristics, the patient desires in terms of quality of life, access to care, it will be a multidisciplinary approach. And then lastly, I do think there is a role for low-dose radiation, particularly for gastric malt, given the efficacy is quite good and well tolerated. And with that, I'm happy to end and then address any questions. Thank you.
Thank you, Dr. Nassov. Great progress in the indolent lymphomas. So the first question is, outside of the clinical trial and in the community practice, how would you recommend first line, second line, and third line treatment for follicular lymphoma?
Great questions, and there's a lot of variables that's going to impact the treatment choice, but most patients will get chemoimmunotherapy for high tumor burden frontline, and choosing your chemotherapy has to do with patient comorbidities. So most will get bendamustine in combination with CD20 because it doesn't have the cardiac risk factors, it doesn't have neuropathy risk factors, and so the toxicity generally is considered to be more favorable. In second line, if patients don't have signs of transformation, then you could consider lenalidomide in combination with rituximab based off of the AUGMENT study, which looks to be quite fit. In third line, there's actually even more options, and that's where the bispecifics, CAR T, an EZH2 inhibitor, tazemetostat come into play. And so again, choosing has to do with patient comorbidities and access to care. We're really excited about the bispecifics and CAR T and how I choose between those two. If I have any concern about transformation, I just didn't prove it either on biopsy or we couldn't get a biopsy, I would lean more towards the CAR over the bispecific. But I think the bispecific is going to have more uptake just because the toxicity profile is perceived to be a little bit better.
So Loretta, I'm trying to extrapolate from the ALL experience where we started using the CD19 bites with chemotherapy and sequence them with CAR T cells and so on. So I'd like to get more in depth in the follicular lymphoma. So you talked about how great the data is with the CD19 CAR T cells, and then you talked about the great data with the CD20 bites. If you have a choice between a CD19 CAR and a CD20 BiTE, which one would you choose?
I think for an older, frailer patient, I would definitely go with the bispecific. For a young, fit patient that's progressing quickly through effective therapy, I'd probably favor the CAR. There was data at ASH from the European group showing that you can successfully sequence a bispecific before CAR, because that's always been a question we've posed, particularly in large cell where the CAR is known to be curative, and it can be successfully sequenced in that bispecific than CAR. And we've seen data with bispecific, it probably but doesn't matter too much. But again, patient-specific characteristics are going to sway me.
So we're always discussing CD20 BiTEs followed by potentially CD19 CAR T cells. Are there any CD20 CAR T cells?
In clinical trial development, yes. There's an auto CD20 that's being developed. There are bispecific CARs, so they're auto CD19, CD20, and then there's an allo gamma delta CD20 directed CAR that's also under.
So Loretta, I know that blinatumomab, the CD19 BiTE, failed in the randomized trial, although it had activity comparable to chemotherapy, and now we're developing a subcutaneous blinatumomab, which we can give 5 times more than the IV. are you reconsidering exploring again blinatumomab in the indolent lymphomas?
Not blinatumomab, but there is actually a CD19 bispecific that's under development that was initially Tineo Bio, but has been licensed by AstraZeneca, and we have that phase 1 study open at Anderson, and it's about to launch into a phase 2 dose expansion in follicular. The efficacy was reported at our Lugano lymphoma meeting this summer with very high response rate, over 90%, and nearly all were CRs in follicular. It has the luxury of a longer half-life where you have less frequent dosing. So I think CD19 bispecifics are still exciting. There are just others that are being developed in lymphoma.
And so I mentioned in ALL, we are using with blinatumomab, with inotuzumab. Has anybody explored, say, BR with CD20 BiTE?
So there are a number of combinations underway, and yes, there are trials out there looking at a bispecific in combination with chemo, both in large cell and in follicular. I think bendamustine may be one that we have a little bit of concerns about, just given its impact on T cell subsets, but definitely it's been combined with CHOP or CHOP-like therapy quite successfully. There is 2 frontline studies that are launching right now in combination with lenalidomide versus our chemotherapy. Just 2 different bispecifics are the 2 different trials. And so I think we don't quite know yet what's the optimal partner, but in large cell lymphoma, you can definitely combine a bispecific with chemo and have quite high efficacy, and the CRS rates are actually lower than what we see with the single agent.
And for grade 3 A or B follicular lymphoma, would you still consider BR?
So an interesting development this summer is the update to the WHO. They're now downplaying the importance of grading, and it's not even required anymore as part of our diagnostic assessment. I think because there's a lot of controversies and poor reproducibility. So it's not going to be wrong for a pathologist to not report grading anymore. That being said, there is retrospective data that suggests there are some concerns about the efficacy with bendamustine-based approaches in grade 3 follicular. How much of that is weighted towards the grade 3B versus 3A, I think is questionable. As of right now, I don't use grading alone to choose my chemotherapy backbone, but that could be one piece of the puzzle that helps you decide if you need an anthracycline versus non-anthracycline approach.
And can you update us on using upfront bendamustine and CAR T cell collection or efficacy? Because I saw some data.
There's questions about pre-exposing patients to bendamustine if you're going to collect for an auto CAR. So far in follicular lymphoma, we haven't defined that timeline for when it matters. In mantle cell, 6 months seems to matter. In follicular lymphoma, we do have some concerns if you have a patient that progresses on bendamustine or shortly thereafter. And in the lysocell data, the durability or the suppression of B cells and the length of hypogammaglobulinemia was actually shorter in that second line population that were POD24, hinting that maybe prior bendamustine exposure within 2 years might be a problem.
Thank you very much, Dr. Nasuti. So next we're going to move to Dr. Julie Vos, who will update us on aggressive non-Hodgkin's lymphoma.
Hi, I'm Dr. Julie Vos from the University of Nebraska Medical Center, and I'll be talking about abstracts on aggressive non-Hodgkin's lymphoma. First one I want to talk about is the SMART STEP trial, and that was presented by Dr. Jason Weston. Just a little bit of background that he presented was diffuse large B-cell lymphoma as far as the differences in outcome for a lot of standard therapies and clinical trials that have recently been presented over the past few years. Unfortunately, most of them previously did not have an improvement in outcome, with the possible exception of the more recent POLA-R-CHIP trial. So he originally presented the SMART STEP study a few years ago, trying to have a run-in with rituximab, lenalidomide, and ibrutinib for patients with diffuse large B-cell lymphoma, and then going into either CHOP or EPOC. And the outline of that is presented here. And he presented very excellent outcomes for this particular patient population. The new study is trying to add additional agents, such as the lenalidomide, tafasitamab, rituximab, and acalabrutinib for an induction therapy. and it's every 21 days. And then the patients would go on to more standard therapy as appropriate. So eligibility for this trial were histopathologically confirmed large cell lymphoma, adult patients, performance status less than or equal to 3, adequate end organ and bone marrow function, and no CNS involvement. You can see the toxicities as noted here are pretty standard and did not have a lot of grade 3 or higher toxicities. So results after looking at the initial evaluation for this, I think were very interesting in that they did 4 cycles of this therapy, non-chemotherapy. They looked at ctDNA in the blood at various different time points. So they reported on the first 30 patient cohort here. If the patients had a complete remission after the 4 induction cycles, they went on to several additional cycles of the non-chemotherapy regimen, plus 2 cycles of standard CHOP therapy. If they had a PR or less, they went on to additional agents plus CHOP therapy for 6 cycles, and you can see the outline of that here. So I think what was most interesting from this particular study were that the patients had a very high complete response rate, and there were also a very high percentage of patients that only needed the 2 cycles of CHOP therapy. Although very early in the study, I think these are promising results, and this is going to be continued to be looked at a little bit further. So the patients in group A, 2 cycles of CHOP plus the backbone regimen, or cycle B, you can see here that there was a very high percentage of complete response rate in both of those arms. So their conclusions were that this targeted therapy alone is safe and effective, had very low toxicity, pretty high CR rate after the 4 induction cycles of non-chemotherapy regimen, 63%, and not as many patients needed to get 6 cycles of CHOP, and a high percentage only needed the 2 cycles of CHOP. This is very early, of course, and there's not a long-term outcome yet, but I think is very interesting. They also had a limited ctDNA or circulating DNA information, but it was undetectable in a fairly high percentage of patients. I'm sure we'll be seeing a further outcome of this and follow-up of these patients soon. The next study I want to talk about a little bit was kind of the opposite of that. There was a 3-year analysis of the ZUMA-12 study where there was an escalation in high-risk patients of diffuse large B-cell lymphoma, as opposed to the last abstract, which was a de-escalation. And this is presented as a 3-year follow-up of the ZUMA-12 study. So in this study, these were patients with very high-risk diffuse large B-cell lymphoma. They had double or triple hit. They had high IPI scores. The patients had a very dynamic 2-cycle induction, and then they went on to receive captogene Solucel or Axicel CAR T-cell therapy after the 2 cycles in these high-risk patients. Standard lymphodepletion and Axicel as per standard of care, except in these high-risk patients, and they went on to look at the primary endpoint, which was CR. This was previously presented, but this is a follow-up of these patients with further follow-up. So objective response rate was 92% and 86% complete response rate, which is much higher than would be otherwise expected in this high-risk patient population. And you can see here, even in the very high-risk patients, double, triple hit, and IPI high score, the response rate and remission rate was quite high. The durability also was fairly good, as I'll go over in a minute. And you can see that these patients with further follow-up have continued to do quite well. Progression-free survival and overall survival is noted here. And among patients who had a complete response, the 3-year progression-free and overall survival rates were 84% and 90% respectively. So much higher than one would expect in this very high-risk patient population. However, there were 8 deaths on the study. Most were due to progressive disease, even despite these very aggressive treatments. One, unfortunately, was due to COVID-19. One was a secondary adenocarcinoma of the esophageal area, septic shock. There were no cases of very severe cytokine release syndrome or neurologic toxicity in this patient population, which was good. And at the primary analysis standpoint, there were some infections and other toxicities that are standard for CAR T-cell therapy, but really nothing out of the ordinary. So I think we're going to be seeing more of this, and potentially a prospective randomized trial also looking at this patient population. So So their conclusions were that with the updated analysis, further follow-up, high rate of durable remissions, fairly safe as far as no high-grade CRS or neurotoxicity. There was good expansion in this patient population, and Axi-cel did seem to benefit the outcome for these very high-risk patient populations. As I mentioned, Zuma 23 is a phase 3 randomized controlled study in this patient population. This regimen is outlined versus standard of care for these high-risk patients. And this is going to be an ongoing study for a while. I'm sure we'll see the results in the future. The next one I'd like to talk about is looking at preliminary results of the EPCOR NHL 1 study. This was an abstract that was I presented there, trying to mitigate the risk of the cytokine release syndrome in this bispecific antibody. So this was a diffuse large B-cell lymphoma study with epcoritamab, subcutaneous bispecific antibody. And this particular population was trying to optimize the treatment and prevention of cytokine release syndrome and neurotoxicity while maintaining this as an outpatient. So optimization included a dexamethasone that was given as pre-medication on the first several treatments, IV fluids that were given within the 24 hours prior, trying to stop antihypertensive medications, and also administration of fluids, as I mentioned before, and also after the therapy. They also had some self-monitoring of temperatures. Hospitalization was not required. The first full dose was given as the third dose as a ramp-up stepping, as we now know that's more safe for patients. And the rates of CRS and neurotoxicity were evaluated. Key inclusion criteria you see there on the left. These are patients that had failed 2 or more prior lines of therapy. Many of them had received prior CAR T-cell as well. So disease-specific characteristics you can see here for 60 patients in this cohort, pretty standard as far as patient population. 68% of them, however, had received 3 or more prior lines of therapy, so pretty heavily pretreated. And quite a few patients, actually over 50%, had prior CAR T-cell as well. Overview of the cycle 1, looking at optimization. Among the 36 CRS evaluable patients, pretreatment with the steroids and IV fluids, as mentioned, were able to be obtained in most patients. And you can see on the line here that the grade 1 and grade 2 CRS were lower, as well as there's no grade 3 CRS in the optimization cohort. And so that's really important because these patients, we try to treat them as outpatients if at all possible, and it's quite safe. This shows the CRS events by dosing period, and you can see the first full dose is on day 15. The prior expansion cohort was on the left there. You can see that there's higher risks of CRS and neurotoxicity, as well as the first full dose on day 15 in the expansion cohort. The CRS events were quite a bit lower, and there were no grade 3 CRS events at all. So the conclusions from this were that CRS prophylaxis with dexamethasone and hydration, as well as getting rid of antihypertensives, really reduced the rate of CRS, and prophylactic hospitalization was not required. And timing of CRS continues to be pretty predictable with this step-up dosing and these measures that were taken. IL-6 levels, which also correspond to rates of CRS, were lower in this optimization cohort. So as far as future patient treatment, this is pretty much what I'm going with for standard of care. Next abstract I'd like to talk about is a 5-year outcome for patients. This is real-world experience looking at axicabtagene ciloleucel in the U.S. consortium. This has been presented previously, but there's further follow-up. These are patients compared to the Zuma 1 study, which is a standard of care study, clinical trial that was done, and a number of patients in this cohort was about 300. You can see the characteristics there. More importantly, there were about 20% of patients in the real-world characteristics that had an ECOG 2 or 3 and more high-risk characteristics that were not originally allowed on the Zuma 1 study. So higher risk patient population. Just to remind you what axicabtagene ciloleucel, the anti-CD19 CAR T, as noted here, 5-year overall survival 42% and progression-free survival 31% at the last time it was presented. In this real-world cohort, you can see here that of approximately 300 patients, The median overall survival of 28 months and 5-year overall survival, 37%, is quite similar to what was seen in the original clinical trial. Cumulative incidence of relapse, about 55%. Non-relapse mortality was 16%. The relapse rates after 1 year are fairly low. However, the non-relapse mortality events do continue to slowly increase over time, and I think that's the important part of this abstract. Infection was the leading cause of non-relapse mortality. You can see the types listed here. Some were due to COVID, some bacterial pneumonias or other types of viral illnesses. And that is something that we have to continually watch out for in this patient population. CD4 recovery is typically greater than 12 months and a very prolonged in a number of patients. And some of these patients never have complete B-cell recovery. Late infections were not necessarily associated with neutropenia, as you can see on this slide. So we have to be mindful of this. Even if the patients don't have neutropenia, they still are very high risk for infections. There's also, unfortunately, a subsequent high rate of secondary malignancies, particularly the myeloid malignancies. You can see here 15 secondary myeloid malignancies. Now, keeping in mind that these patients were very heavily pretreated, many had failed transplant or failed multiple other therapies. So conclusions were that about 29% of patients remain in remission at 58 months follow-up, and despite 43% of them not being eligible for the original ZUMA-1 study. Non-relapse mortality was about 16%, and infections and secondary malignancies are the biggest issue, particularly long-term in these patients. Relapse after a year is uncommon. Another one I want to talk about is ibrutinib combined with venetoclax in patients with relapsed refractory mantle cell lymphoma, presented by Dr. Wang during the study, the Simpatico study. This was 267 patients. You can see the eligibility there, randomized to standard ibrutinib plus placebo compared to ibrutinib plus venetoclax. You can see the randomization here and the outcomes. Median follow-up is now about 51 months. And toxicities as listed there, and progressions. Baseline characteristics were very balanced, as noted in this particular slide. Primary endpoint was investigator-associated PFS, and you can see there was an improvement in PFS for the combination versus ibrutinib and placebo. Complete response rate was significantly improved by the combination as well, as you can see in the slide, and duration of response. Overall survival was not statistically significantly improved in this patient population, and you can see the curves there. These patients, of course, could go on to other therapy after that. So their conclusions were that ibrutinib and venetoclax after that. So their conclusion achieved a statistically significant improvement in PFS compared to ibrutinib plus placebo. CR rates were higher. Overall response was not statistically improved, but numerically there did appear to be some benefit. Maybe with further follow-up there will be. Safety profile seemed to be consistent, and overall this addition of venetoclax to ibrutinib had a favorable risk-benefit ratio. Pirtobrutinib is another abstract I wanted to follow up on. This was a further follow-up of a previous presentation from the Bruin study. Pirtobrutinib is a highly selective, non-covalent or reversible BTK inhibitor, as you can see here, and has been studied now in patients in multiple different categories. Baseline characteristics for patients with mantle cell lymphoma. You can see most of them had received a prior BTK inhibitor and either progressed on it or were intolerant of it. There were a few BTK naive patients in this study as well. Pretty high-risk patient population. Efficacy in mantle cell lymphoma who had received a prior BTK, noted in this slide, and though not all patients responded, there was a pretty high response rate of about 50%, about 25% complete response rate in this patient population. You can see here the duration of response, progression-free survival, and overall survival in this very high-risk patient population. So although it does not benefit all patients, certainly some of these high-risk patients do have benefit from this agent. So with longer follow-up, pirtobrutinib continued to show some promising efficacy in these very heavily pretreated patients, and they had in them mostly in the received prior BTK inhibitor. The treatment was very well tolerated in most patients. and low rates of discontinuation. A randomized phase 3 study has been accrued. We don't have the results yet. And comparing pirtobrutinib to BTK naive patients in BTK naive patients with mantle cell, and that's a prospective phase 3 randomized trial that we'll be looking forward to in the future. Now I want to turn to looking at the end of treatment or middle of treatment, looking at circulating tumor DNA. This is a really important area that I think we'll see a lot more studies in over the future. A couple of studies in that realm. This one presented by Dr. Mark Warczewski, looking at end of treatment response and also looking at more sensitive, ultrasensitive circulating DNA testing. So previously, the circulating DNA was, ctDNA was looked at and found to be really important for this patient population. 20% of this particular patient population who had circulating DNA, you can still see that they had improvement in outcomes. So it's important to have a very highly sensitive test. PET scans don't always pick that up. So ultrasensitive circulating ctDNA detection by technologies has improved over time. So currently available CAPP-Seq has a sensitivity, as you can see there. There's more ultrasensitive testing that is being developed, and one that was presented here was called phase-Seq. This was developed at Stanford and now is being evaluated in a company called Foresight. So ctDNA, looking at this very sensitive technique, you can see patients who are negative at the end of therapy or negative after 2 cycles is very predictive for outcomes for patients. This is previously presented information. Patients looking at ctDNA, even if the PET scan was negative, if the ctDNA was positive, as in the red line here, it was very predictive of outcome. So complementary to PET scans. This is a clinical trial from the NCI where this technique was looked at. Patients had an induction of acalabrutinib for 2 weeks, and then depending on their reduction in size of tumor, they were randomized to either the combination or standard care chemotherapy without acalabrutinib. Patient characteristics, as you can see here, pretty high-risk patients, older, high IPI. Progression-free survival for ctDNA, you can see here, ctDNA not detected, improvement. This is only after 2 cycles, so detection after 2 cycles. That ctDNA not detected had a much better outcome as compared to ctDNA detected after 2 cycles, and progression-free survival is noted there for 2 years. Additional procedures at the end of treatment to determine remission. So end of treatment, typically we would do a PET scan to determine remission, and that's kind of a standard of care as used now. PET positive, there were 14 of those patients. They, of course, looked again at ctDNA at different time points. And you can see that if they were PET positive, there was a pretty high level of progression, but there were some patients that actually did not progress. PET negative, there were 40 patients. And if their MRD by this sensitive technique was negative, they actually had 0 progressions, and there were 35 of those patients out of the 40. If the patients had a PET negative, but their MRD was positive, 4 out of 5 patients progressed. So very complementary results on these 2 tests to be done in conjunction with each other. So conclusions were that ctDNA by this very sensitive phased Seq technique was prognostic after 2 cycles and also at the end of treatment. And undetectable ctDNA by this very sensitive phase technique at end of treatment predict for a very low likelihood of progression, and really was valuable, probably more valuable than PET, but also very valuable in conjunction with PET. You know, additional procedures may be helpful, but these 2 together were very powerful. And one key conclusion they had was that salvage therapy should not be delivered based solely on an end of treatment PET, that you should also look to have a positive biopsy or to wait for a frank relapse. One other study that also looked at ctDNA as an early predictor was this study that was presented, looking at the same test, predictors for patients receiving lisocabtagene maraleucel CAR T-cell therapy as second line. This is from the randomized transform study. So undetectable ctDNA after liso-cel correlates with a very durable blue line finds that patients who were ctDNA negative had a much improved outcome. And this is predictable even early at day 15 after lysocell, and then it was tested again at 3 months. Detectable ctDNA identified patients in CR by PET at very high risk for relapse. Again, you can see here that PET at 1 month and also at 12 months, if the ctDNA was positive, it was predictive of a relapse rate that was much higher than the ctDNA negative patients. So from this study, they demonstrated a very high value of assessing minimal residual disease and looked for very deep and durable responses in those ctDNA negative patients treated as second line with lysocell. And you can see that the undetectable ctDNA patients did quite well. More patients achieved undetectable ctDNA status over time. And so it is important to perhaps not go just by the early ctDNA, but follow up those patients. And ctDNA was associated with progressive disease, a risk that was fairly high. Similar longitudinal analysis evaluating this profile in looking at the other arms of therapy is undergoing progression. So conclusions from all of the different abstracts that I talked about today. For induction chemotherapy, future studies with considerations for different types of diffuse large B-cell subtypes, such as the activated B-cell, germinal center B-cell, or double hit patients and patient characteristics. We need to look at the risk models, and possibly we'll have studies that either escalate or de-escalate based upon the patient characteristics, the pathology characteristics, also early analysis of ctDNA or PET, as was done with a lot of these studies. So I think a lot more patient-specific therapies we'll be seeing in the future, trying to either escalate or de-escalate our treatment. For salvage therapy, bispecifics, CAR T-cell earlier in lines of treatment are definitely the trend, and I think we'll be seeing a lot more of these studies in the future. For mantle cell lymphoma, use of BTK inhibitors earlier and in combinations, I think is going to be the way to go in the future. Perhaps also newer generations of BTK inhibitors that may have improved outcomes, less toxicity, or be more specific for some subtypes of mantle cell may also be important in the future. And then finally, the circulating or ctDNA in diffuse large B-cell lymphoma. We're looking at much more sensitive techniques that are currently in trials. And as you can see from the abstracts that I presented, they were quite predictive of outcomes, and particularly when used in combination with PET scans, are very predictable of relapse. I think we'll be seeing a lot of this in clinical trials and hopefully coming to us as standard of care in the near future. Thank you. I'd be happy to answer any questions.
Thank you very much, Dr. Vos. So a lot of progress in the aggressive lymphomas. The first question is, are you using polatuzumab, the CD79 antibody, in addition to our charts of patients?
Yes, so the data is quite strong in patients that are a little bit higher risk, according to the randomized trial. So we've chosen to use polatuzumab R-CHP. So you drop out the vincristine when you do that in CHOP. And we've chosen to do that in patients that have IPI 3 or more and have found that mostly with advanced stage disease, and have found that to be just as well tolerated, no difference than our CHOP. And at least in the randomized trial, it did have a better outcome, especially for those higher risk patients. So that's who we've chosen to use it in.
So there's a patient with diffuse large B-cell lymphoma, multi-site nodal relapse, received CAR T cells and has severe cytopenia now. How do you treat this?
Yeah, that's something that we're recognizing more and more, is that these patients can have cytopenias for quite some time, particularly if they've been heavily pretreated with other therapy or gone through transplant before. So there's really not a lot you can do other than support them with our usual methods of transfusions if needed, prophylactic antibiotics. Of course, they're on some of those anyway for at least a year after CAR T. And then to be able to use growth factor if you need it. And some patients need that for a very long period of time. That is, we're finding out a little bit of a precursor in some cases to secondary MDS or some other things. So if they do have prolonged side effects, do a bone marrow and make sure they don't have kind of underlying MDS that's come out.
So you showed very exciting data in the high-risk large cell lymphoma in 37 patients who received 2 R-CHOPs, I think, the axi-cell, with a 3-year survival of 80%. So do you think this in the future will be a new standard of care? Where is this going, do you think?
So the study I showed is a pilot study, and obviously did look very exciting. Of course, there's not every patient in that situation that could go through all that treatment. There is a randomized study, standard of care versus that regimen that is going to be started in the near future. So in the upcoming years, hopefully we'll see those outcomes.
Can you comment on the risk of secondary T-cell lymphoma after CAR T-cell therapy?
So as you may have seen in the news, there were some reports of secondary T-cell lymphomas that were after CAR T-cell therapy. Some of this we do see in lymphoma patients with any treatment, just as a background, but this was alarming that there were so many. In fact, we had one here at our center. And it's a very small percentage of patients, and these are patients that have, of course, been through a lot of other treatment, have no other options. So I still think in that situation, I would choose CAR T-cell for that patient. As we move this therapy up further with patients who are less heavily treated, I would imagine that this percentage and this abnormality would go down, but we'll have to see. I still think the benefits outweigh the risks.
So there's a question about CLL, the use of ibrutinib venetoclax in CLL. So where would you use the combination of ibrutinib venetoclax, and for how long? And is there an additional value of the CD20 antibodies?
Yeah, so for certain, very high-risk CLL patients, we do certainly use that combination, and sometimes do add obinutuzumab, or even start with that to try to get the white count down. I would say for your average CLL patient, I don't necessarily use that combination. I either give them the choice of obinutuzumab venetoclax, or a zanubrutinib or acalabrutinib, possibly with obinutuzumab if their white count's very high. The problem is, of course, that 2 very high-cost oral medications for some people are just out of reach. So I think we'll have to use that in patients who really need it, the very high-risk patients.
And about frontline therapy of mantle cell lymphoma, you've shown data with ibrutinib venetoclax in the salvage. It looks very good. Why are we not using non-chemotherapy regimens, say with ibrutinib venetoclax or acalabrutinib venetoclax in frontline mantle cell lymphoma therapy yet?
Well, I think there are certain patients where that is a good option. Of course, we have to be able to get that for the patient with respect to FDA approval, cost of the medicine, et cetera. So I think we will be seeing more and more trials that use those medications earlier in the course of the disease, and hopefully they'll be more available in that case. But they are very good medications for these patients. So hopefully we'll be able to see that earlier soon.
If you have a patient with large cell lymphoma who is PET-CT positive and ctDNA positive, would you still recommend a biopsy to confirm the relapse, or would you go based on those 2 pieces of evidence?
I think under the current situation, I would still recommend a biopsy just to be sure, but certainly the possibility of the biopsy is going to be positive are very high in that situation. As we get more and more information with ctDNA and potentially FDA approvals and that sort of thing, that will hopefully in the future be able to be used. But as of today, I don't think so. We would take a biopsy.
Do you recommend the colonoscopy in a patient with diagnosed mantle cell lymphoma? And what is your frontline therapy in a patient with mantle cell lymphoma?
Yeah, very, very controversial situation. I don't necessarily recommend a colonoscopy with biopsies unless the patient is symptomatic, because we assume that mantle cell is disseminated at the time of almost all patients. And if you use patients, they're almost always positive. So I sort of assume they're positive. Upfront therapy for older patients, I still do use bendamustine and Rituxan. For younger patients, I think the triangle regimen of trying to add a BTK inhibitor potentially would be a good option, but it's still a little bit up in the air as far as what's right for each patient population, and you have to use your judgment with respect to age and other comorbidities.
And your current approach for double hit lymphomas?
We use dose-adjusted R-EPOCH for those patients.
Thank you very much, Dr. Vos.
Thank you.